So this was a question given regarding pulmonary embolism. Now, pulmonary embolism is one of the diseases where unexplained breathlessness is the most common symptom. This is a true statement. Whenever heart failure or pneumonia fail to improve with standard medical treatment, you should also consider possibility of pulmonary embolism. See, because pulmonary embolism is something which we generally miss. You don't think pulmonary embolism presents as an isolated disorder. It can also be present with some other associated condition. Many a time patient admits to the hospital with COPD heart failure. You start treating it, it will not improve. You think there is something else, do a CT pulmonary angio, you find pulmonary embolism. Then patients with high likelihood of venous thromboembolism should undergo D-dimer test first without obligatory imaging test. We know that there is something called as Wells criteria. In Wells criteria, depending on the score, if the score is more than 4, we consider it as high likelihood pulmonary embolism. If the score is not more than 4, it is low likelihood pulmonary embolism. If it is high likelihood, the next step should be investigation of choice because the chance of pulmonary embolism is high. Here, first we do a blood test called as D-dimer. Only if it is high, then you go for imaging test called as CTPA. If it is normal, one can exclude pulmonary embolism. So this is the standard algorithm discussed. So here with the high likelihood, it is CTPA first. So this is wrong. You should select the option where 1 and 2 are only right. Then next question, consider the following criteria, which if present is indicative of exudate. See, there is some controversy in framing this question. Actually, most guidelines mention that any one of the following. You no need to have everything to call it as exudate. Any one of the following is exudative pleural effusion by definition. So it can be pleural effusion protein by serum protein more than 0.5, pleural effusion LDH by serum LDH, because exudation means it is active damage to the membrane. So within the fluid, protein can be excess, LDH can be excess. And the third criteria is also pleural fluid LDH more than 2/3 upper limit serum LDH. So it is the same. 60% is, 0.6 is roughly 2/3. If you take in terms of fraction. So to call it as exudate, actually 1 is sufficient. But all these 3 will come under exudative effusion only. So this will be the answer. To call it as exudate, either protein ratio should be high, LDH ratio should be high. Then which of the following are correct regard to clubbing? See, clubbing is nothing but bulbous enlargement of, so this is clubbing means bulbous enlargement of, like a bulb, it will enlarge, of fingers and toes. So it can happen both in fingers and toes. It does not involve toes is wrong. Now this happens in variety of situations. The reason is whenever there is a systemic disease in your body, there can be deposition of inflammatory mediators at the tip of fingers, and that inflammatory mediators can also contain growth factors which will result in proliferation of the connective tissue in the finger and toes. The usual causes of clubbing, if you come system to system in CVS, it is cyanotic congenital heart diseases, subacute endocarditis. Whereas in respiratory system, the famous causes are bronchiectasis, lung abscess, bronchiectasis, lung abscess, malignancy, ILD, all chronic conditions. There are also other conditions, but these are important. And usually it can be symmetric. It can involve the finger symmetric. It might be associated with malignant conditions also. Then cystic fibrosis related bronchiectasis. Cystic fibrosis, the problem is bronchiectasis. After doing lung transplantation, because all the your lung is again brought back to normal, so now your lung is functioning normal, so the bronchiectasis related inflammation has subsided. Sometimes clubbing can recede. So this was an observation. After lung transplant in cystic fibrosis, they have noticed clubbing to recede. So this is a fact-based observation. So here, apart from 2, everything seems to be right. So the best answer will be 1, 3, 4. Clubbing is bulbous enlargement of fingers and toes due to deposition of inflammatory mediators, especially growth factors, resulting from chronic inflammatory disorders such as bronchiectasis, lung abscess, malignancy, ILD. In cystic fibrosis after lung transplant, it can reverse. That was an observation. Then coming to Lofgren syndrome. Again, this question we have seen in sarcoidosis. This Lofgren syndrome is an acute manifestation. It is a phenotype. It contains erythema nodosum, hilar lymph node enlargement. Then there can be arthritis. And usually this is acute presentation. It can have fever. Along with this, eye involvement can be seen. Now this is an acute illness, yes. And sarcoidosis, autoimmune disorder, it is more common in females. This is true. Has arthropathy, uveitis, this is also true. Fever, erythema nodosum, bilateral lymphadenopathy. Actually, this question they have not framed properly. Hilar lymph node enlargement should be there. Maybe examiner is thinking when they say bilateral lymphadenopathy, he might be referring it to bilateral hilar lymphadenopathy. So the answer, all 3. By definition, in most of the standard books, sarcoidosis means erythema nodosum, hilar lymph node enlargement, arthritis. It can have fever, it can have uveitis, and extra edge, this is self-limiting condition, a form of sarcoidosis, and generally good prognosis. Whenever I say self-limiting, mostly it should have good prognosis. Self-limiting, mostly good prognosis. This many times I must have discussed in the class. BODE index always they'll ask you what is B, what is O, what is D, what is C. B stands for BMI, O stands for obstruction. So this is a prognosis index in COPD to assess how well patient can do after developing COPD. D stands for dyspnea grade. This can be known by Modified Medical Research Council scale. And E stands for exercise capacity. This exercise capacity can be known by distance covered in 6-minute walk test. So observe here, students, they have asked the distance covered in 6 minutes is indirect measure of which variable. So this is exercise capacity. When they say 6-minute walk test, it indicates exercise capacity. For NEET also, make sure you know what is BODE index. BMI, obstruction, dyspnea, exercise capacity. Then sixth question, for diagnosis of pulmonary TB, this is very easy. Now for diagnosis of pulmonary TB, we use cartridge-based nucleic acid amplification test. Yes. We can use Zn staining conventional. An improvement of this Zn staining is LED, light emitting diode, fluorescent microscopy. This is an improvement of conventional Zn staining. In conventional Zn staining, we use only the stains to identify the organism. Here we use fluorescent stain. So from the black background, you can see fluorescent organisms present. This is also true. And culture in Middlebrook media, rarely done, but still it can be done. But we don't use any blood test for diagnosis of pulmonary tuberculosis. It is in the lungs. The disease is in the lungs. So there is no point in using blood test here. So the best answer will be 1, 2, 3. It is not blood test. It is culture. This is staining. This is molecular assay. So we should appreciate the examiner because he have taken from each and every group. One is molecular assay, one is culture, one is staining. And this is the last question. Which of the following are true regarding ARDS? So they have asked regarding the pathology of ARDS. Generally, it is having 3 phases, and they have also asked about treatment and stratification. So this is the stratification. We know it is based on PaO2 by FiO2 ratio. If it is 200 to 300, it is considered mild. 100 to 200 is moderate. Less than or equal to 100, it is severe. So this statement is right. Then option 3, low tidal volume mechanical ventilation has significant lower mortality. This is also true. Why we give low tidal volume mechanical ventilation in ARDS? To avoid ventilator associated lung injury. So definitely 3 and 4 options are right. Now let us see 1 and 2 options. What is this exudative phase? What is this proliferative phase? Now the first event in the pathophysiology of ARDS is there is damage to alveolar epithelium and capillary endothelium at multiple spots. So at multiple spots there is a damage happening like this. Because of this damage, bad cells from your circulation called as neutrophils will gain access. So this will result in increased permeability to neutrophils. that will result in neutrophil mediated, wherever neutrophils go, what it will do? Inflammatory damage and exudative fluid. So there will be lot of neutrophils, inflammatory damage and exudative fluid formation. So this stage is called as exudative stage. This damage and alveoli filled with inflammatory exudate is called as exudative phase. Now if you diagnose the disease properly and treat it exactly, most of the patients will recover by the next 1 to 2 weeks. In the next 1 to 2 weeks, you have something called as proliferative phase. So if you handle this patient properly, if there is an infection, if you treat it properly, if you reduce the ongoing damage, there will be recovery and proper alveolar epithelial proliferation. Initially, the epithelium is damaged. Both type 1 type 2 will be damaged. If you treat this disease properly, it will get proliferated and the disease generally ends here. But by chance, if you don't identify the cause and don't treat it properly, it goes into a dangerous phase called as fibrotic phase. So where all the lung will is damaged and it starts to shrink. And this fibrotic stage is associated with lot of mortality. 3 phases. First week is exudative. This is the damage phase. Second and third week, it is the recovery phase if you treat the disease properly. So you are having time only this 2 weeks. If you don't treat here properly, they can go into fibrotic phase, which can result in mortality. So the question given here is exudative phase is not 7 to 21. This is proliferative phase. It is 0 to 7 days. So this is wrong option. Characterized by proliferation of type 2 pneumocytes? Yes, because if alveolar epithelium has to proliferate, type 1 have no capacity to regenerate, it is only type 2. So the answer is 2, 3, 4. They have selected the topics also very well. ARDS, sarcoidosis, pulmonary embolism. In that way, tuberculosis, they made sure everything is covered. Okay. So this completes the UPSC respiratory medicine recall. It was a good paper and also doable. Only thing, you should have some logical thinking at that point of time. And all the very best students, all the very best for your upcoming NEET PG. I am very sure it will be of the similar pattern. There will be more of direct questions. So thank you and all the very best students.